The next part now is acute tubular necrosis. Now, for acute tubular necrosis, you need to know that we have the risk or the causes of acute tubular necrosis. What are the two main pathogenesis via which you can have acute tubular necrosis? The first main pathogenesis via which you can have acute tubular necrosis is ischemia. Is it clear? And the second major pathogenesis via which you can have acute tubular necrosis is toxic. Is it clear? And these toxic ones are the toxic products that are capable of being filtrated. Is it clear? And then the last disorder, the last cause that can result to acute tubular necrosis is we have tubular obstruction. Is it clear? So those are the three major pathophysiologies via which you can have acute tubular necrosis. Now, let us visualize now why I am speaking about all these pathophysiologies. So we need to know that what actually we have what is called the nephron. Is it clear? So let's say this is our nephron. This is a proximal convoluted tubule. This is a loop of Henle going to the distal convoluted tubule, and then we have your collecting duct. As such, so this is your proximal convoluted tubule, this is your loop of Henle, you have your distal convoluted tubules, and you have the collecting duct there. So let's say that this is your nephron. Now we need to know that what inside the nephron we have what is called the glomerulus. So this is your glomerulus here with the afferent arteriole entry into the glomerulus, and then after you're going to have the efferent arteriole which goes out. Is it clear? So this is, let's say this is the glomerulus here. So this is the glomerulus here. Now, after the efferent arteriole goes, you need to know that, let me put it better in shade. After the efferent arteriole goes, you need to know that you're going to have arteries that is going to supply now the tubules. Is it clear? You're going to have arteries that supply the tubules. Is it clear? That supply the tubules only. Is it clear? You have arteries that supply the tubules, and these arteries are called the peritubular capillaries. So these are the peritubular capillaries. Is it clear? Peritubular capillaries. Now, I want you to understand a point. You need to know that what? You need to know that generally, when blood comes in the kidney, so this is the first diagram. When blood comes in the kidney, is it clear? You need to know that the blood comes at the level of the cortex, then it goes inside the medulla. The cortex is going to be differentiated from medulla is by the fact that what the cortex is going to be more dense than the medulla, and then the pelvis is much more instant, and the pelvis is less dense. So the cortex is very dense, then later on you have the medulla. So when you are seeing this on echography, the cortex is going to be hyper-echogenic, then the medulla is going to be much more echogenic. It's going to be echogenic, but this one is going to be hypo-echogenic. So we have hyper-echogenic and hypo-echogenic. Now you need to know that the medulla is going to be supplied by the blood vessels before. So what happened is that we have first the renal arteries. The renal arteries now divide into the segmental arteries. The segmental arteries divide now to produce the arcuate arteries. Is it clear? And then the arcuate arteries are the one that are going to divide now to produce the different arteries that are going to supply the different nephrons. But now you need to know that what the arcuate arteries supply the interstitium of the kidney. Is it clear? The arcuate arteries here supply the interstitium of the kidney, while these other arteries here, which are the afferent arterioles, are going to be supplying the nephron at the level of the glomerulus. So what does it mean? It means that the glomerulus is going to have more blood supply first than the first one that has a good blood supply is going to be the one that directly take from the arcuate arteries. Is it clear? And the one that directly take from the arcuate arteries is the interstitium. Is it clear? At first. Then the next one that also take blood also directly from the arteries, you have the glomerulus. Is it clear? Now let's speak about the tubules. You need to know that what the blood that comes in the glomerulus needs to be first filtrated. So it means that what all the pressure, hydrostatic pressure that was inside inside this blood is going to reduce by the glomerulus. Is it clear? So it means that what the remaining blood that goes in the efferent arteriole, into the peritubular capillary for the supply of the tubules is extremely small. So it means that what every time there is hypovolemia, is it clear? Every time there is hypovolemia, the major structure that suffer the most is the tubules. Is it clear? The glomerulus is going to be very well supplied. The interstitium also is going to be very well supplied. So every time there is ischemia, the man that is going to receive the least blood supply, because the blood supply coming to the tubule, that is the peritubular capillaries, is going to first pass through the glomerulus. So most blood pressure has been taken by the glomerulus. So the last to be supplied is going to be the tubules. Is it clear? And since the tubules is last to be supplied, in case of hypovolemia, the man that is going to be suffering is going to be the tubules. So that is going to be called acute tubular necrosis by a mechanism of ischemia. Is it clear? So now that was an aside in order to explain how ischemia can result to tubular necrosis. Now I want to explain the fact that what ischemia can either result to hypoperfusion of the kidney. Ischemia can result to hypoperfusion of the kidney, and it can also be as a result of hyperperfusion of the kidney. Is it clear? Now some people are going to ask me why. Is it clear? And I'm going to answer them. So why is it that you have both hypoperfusion? In case of hypoperfusion, when you have dehydration, is it clear? You are going to have reduced renal blood flow. That's going to reduce the flow to the peritubular capillaries and reduce the flow to the tubules, as you can see from this diagram. But we need to know that also hyperperfusion in the kidney, like in the cases of malignant hypertension. Is it clear? When you have malignant hypertension, you have what is called a pressure natriuresis. Is it clear? In case of malignant hypertension, you can have pressure natriuresis. And pressure natriuresis, what does it do? What happens is that what when you have hypertension, is it clear? It's going to increase the renal blood flow. Is it clear? It increases the renal blood flow. So the flow that comes here with pressure is going to be very high. So this is going to cause more sodium ion to be filtrated. Is it clear? So sodium ion is going to enter more of the filtrate. That is called pressure natriuresis. Is it clear? It causes more sodium ion to be filtrated. So since more sodium ion is filtrated, you're going to have less sodium ion in the peritubular capillaries, which are going to be helping the reabsorption of fluid. So it means that what you're going to have more loss of fluids. Is it clear? You're going to have more loss of fluids. Is it clear? Now, if you have more loss of fluid, you need to know that what the compensatory mechanism for a loss of fluid is going to result to what? A RAS system activation, a renin-angiotensin-aldosterone system activation. And the renin-angiotensin-aldosterone system activation results with the production of angiotensin. And angiotensin is going to increase again the blood pressure. So you are going to have a vicious cycle where the high blood pressure is going to result again to more high blood pressure, that is going to result to more reduced renal perfusion from the pressure natriuresis. And at the end, you are still going to have the ischemic acute tubular necrosis from a reduced fluid perfusion of the kidney. I hope you're understanding very well. Now, the second mechanism that you can have tubular necrosis is via toxic, that I'm going to explain in the later tutorial.